laboratories. I'll present some data from our company, but only as a prism into human physiology, not to try to sell anything today. I'm also a cardiologist who was very frustrated by the real-world population-level problem of cardiovascular disease, our inability to solve the known risk factors leading to cardiovascular disease in the real world, and dismayed on behalf of my patients by the idea of administering insulin as a treatment for this disease. And that's sort of how I got started in this whole game. And also, I'm a scientist who saw the early literature on bariatric surgery and sort of as a naive person from outside of the field, became really enamored by what surgery can teach us about the role of the GI tract in human metabolism. And we'll talk about that as well. You know, as a cardiologist at IFSO, I feel like a little bit of an outsider. And I'll tell you, in medical school, I always had that. I kind of relished that role. I would sit in the back of the lecture hall or stand on the side and watch the lecture as it was going on. It was very interesting to me to pretend that I was an outsider looking in on the lecture so I could understand the setting in which the lecture was taking place and the context of the lecture as much as the material of the lecture itself. I find that in science, and in my history in science, we often take a very ground level view of what's happening. What is happening to this molecule or that molecule? What's happening to this pathway or that pathway? And it's useful every once in a while to try to lift yourself up to 30,000 feet and see the forest but for the trees, and realize that what you're looking at is not a set of trees and a walkway, but really sort of a beautiful image of the Amazon rainforest. So how do we lift ourselves up and see the forest rather than seeing the trees? And then what does that teach us about the science that we're actually exploring? So the International Diabetes Federation told us this year that in 2040 there will be 640 million type 2 diabetics around the world. Yesterday, in Diabetes Care, a wonderful publication out of Yale showed that for all of the drugs that we've developed in the last 15 years for type 2 diabetes, population-level control of diabetes remains stuck at 50% of patients who are well-controlled and 50% of patients who are poorly controlled. So 40-some molecules approved by the Federal Food and Drug Administration in the United States, and yet over 15 years, absolutely no improvement in the population-level control of the disease. What does that say? It says that there's a tremendous urgency for innovation in cardiometabolic disease. It also says that all of the molecules that we've been developing may lower blood glucose in very well-controlled clinical trials, but they leave a lot to be desired in the population-level management of the disease. So I'd like to turn our attention to the gap that needs to be bridged from animal data to controlled randomized trials to real-world population-level experience. And as many of you are surgeons, I think one of the things that you can appreciate about surgery is the guaranteed compliance that comes from a surgical intervention and the value that that can have in achieving better population-level control. Surgery is invasive, and surgery is not for everybody. So the key point here is how can we learn the lessons of surgery in order to innovate in a way to address the population-level problem of the disease in a way that drugs are not proving the ability to do. And for me, the pathway to innovation started with identifying a clinical problem from the mouth of my patients and thinking very hard about that and thinking about what the core problem is. And then using experiences from a wide variety of of clinical observations to try to hone in on an intellectual model to help us understand that disease state a little bit better. And once you have an intellectual model, then you can apply rigorous testing of that model in order to try to develop, hone your model, and hopefully improve your technology or your approach. So when I was a PhD student with Bert Vogelstein at Johns Hopkins, with a clinical problem that he faced was sporadic colon cancers, which in the early 80s had no real therapies available, chemotherapies available to it. And he saw, sort of the clinical observation that he made, was that there were certain young patients, he was a pediatrician, with familial adenomatous polyposis, or HNPCC, who were acquiring colon cancer through an autosomal dominant mechanism, And he asked himself the key question from the clinical observation to get to the intellectual model. What can FAP and HNPCC teach us about colon cancers in general, and then how do we use that in order to try to develop new ways of treating the disease? So with respect to the observation of FAP and HNPCC, he recognized there are heritable mutations in oncogenes and tumor suppressors that can lead to cancers. And then he said perhaps sporadic colon cancers also develop the same sorts of mutations, and in so doing, that develops a stepwise tumorigenesis model for how we develop colon cancer. And it's that sort of innovative insight that comes from a clinical observation turned into an intellectual model that I've tried to apply to my observations in cardiometabolic diseases like diabetes. So my problem started with a patient with type 2 diabetes, poorly controlled, who had had a heart attack and came to see me in my clinic when I was a fellow, whose A1C was 8.5, but he did not want to progress to insulin. And I know that the guidelines tell me that he should be moving on to insulin because he was failing oral medicines, but I also knew that he really did not want insulin. And it occurred to me, most of my patients to whom I even prescribe insulin are not even actually taking it 1 year later. And while the guidelines might tell me that I should prescribe it, there's really no good data suggesting that insulin is a good therapy to prevent a second heart attack in this patient, right? And yet, we somehow ended up with a diabetes treatment algorithm that is extraordinarily complex, which makes you sort of wonder if, how did we get here? How did we get to a point where we have so many different molecules and so many very clear-cut recommendations from societies, but one that works so poorly in the day-to-day practice? So I found myself scratching my head and looking for an alternative. As a cardiologist, that's sort of I was not sort of deeply embedded in the endocrinology or bariatric surgical literature, but I somehow stumbled upon the literature of Dr. Porys, not this literature, but it was sort of, but more these two key papers. One from 1995, which showed this unexplained improvement of type 2 diabetes in patients who he had been following over more than a decade. You all must be more familiar with this than I am, so I'm not going to belabor the details. But some completely random observation of diabetes improving in patients who had undergone a surgery for obesity. That in itself was a random observation from Dr. Mason, as I'm sure you all know, which is a surgery originally developed for peptic ulcer disease and gastric cancer. Ultimately was found to be a bariatric surgery. So we have these incidental clinical observations that we can leverage to our advantage, and there's sort of a very strong history of that. And we have to continue to be thoughtful about applying those lessons as we think about further innovation in this field. 10 years passed, and Drs. Dixon, Porys, Schauer, and others write an editorial in Diabetes Care. Why the reluctance? So we see that even though there may be a tremendous clinical observation, there has to be pull-through to clinical implementation for that observation to be relevant. So we have to ask ourselves not just what is the observation, but we have to ask ourselves how do we pull it through to implementation? I found myself asking a slightly different question, which is really, there's a lot of things going on in the surgery, but I was trying to make sense of it in my own mind. Sort of principal component analysis tells you that you have motivated patients, they undergo caloric restriction, then there's gastric reduction, the duodenum is excluded. There's so many different things going on. How do I make sense of all of these different changes and what they might be doing to allow this benefit that we are seeing? But because I refer patients for cardiac surgery all the time, I sort of asked myself this thought experiment. Imagine if a cardiac surgeon told you that he had been operating on 1,000 patients with coronary artery bypass graft for some random reason. And imagine if he told you that the subset of patients who had come in with angina were having remarkable resolution of their angina immediately after the surgery. Well, we would immediately be wondering, partially because we know what the answer is, what it is that surgeon bypassed that made the angina so much better. We would then thereby discover atherosclerotic disease, and then we would develop a hypothesis about the role of coronary artery disease in contributing to angina. And even if you didn't know a priori that atherosclerosis causes coronary artery disease and angina, you would be able to infer that by the random observation afforded by this surgeon's observations. And as someone who was trained in molecular genetics, this was a really amazing insight, because surgery offers organ-level physiological human experiments that are teaching us really important lessons. And ever since the 70s and 80s, as we've turned our attention in basic science laboratories to cellular and molecular physiology, we can see a lot of activity at the ground level, and it's very hard to make sense of what's happening at the ground level. But if you lift yourself up to the surgical experience and the organ level physiology, you can see patterns where no patterns exist at the ground level. And so what would that analogy be? What are we bypassing? So again, naively, I ran into the research of Drs. Francesco Rubino and David Cummings, and that was sort of my first observation, was this Annals of Surgery paper from 2006, showing that just the exclusion of the duodenum alone seems to have an improvement in glycemia, that this improvement seems to be weight independent in these animal experiments. And since we know in humans as well as in animal mechanistic work, there's been tremendous amount of research following up on these observations, elucidating an insulin sensitization mechanism, an improvement in glycemia, an improvement in liver fat, all after a DJB surgery in animals as well as in humans. Okay, so now the surgery is sharpening the focus on the role of the duodenum. Then, in early 2010, I saw this fantastic paper that showed that a patient who had had a gastric bypass surgery had a gastric jejunal anastomotic leak and could not be fed via the mouth anymore. And so the physicians became concerned about nutrient insufficiency, so they put in a G-tube, and then through the G-tube started to feed the patient and noticed that his glycemia worsened. So after the anastomotic leak healed, they did a careful experiment in the same individual on 2 successive days of a glucose tolerance test, either via the mouth or via the G-tube. And they demonstrated dramatic differences in the profile of the glucose tolerance curve. We've heard this morning and yesterday from Dr. Cummings that when you do this in a